Welcome to the webinar, Enhancing Case Acceptance and Achieving Optimal Results with Clear Aligners. The lecture is being presented by Dr. Carrie Witten, DDS, and we are going to begin shortly. And with that, it is my pleasure to introduce my esteemed colleague, Eduardo Al-Dahuli. He is our senior marketing manager, almost left the MM out, here at National Dentex, and he does oversee our clear aligners program. So feel free to reach out to him with any questions, and we'll post the contact information shortly. And now it is my distinct honor to introduce Dr. Carrie Witten, DDS. She has served the Omaha area since 1997. I almost said 79. Then you would have been practicing dentistry since you were 0. After graduating from the University of Nebraska Medical Center College of Dentistry, she holds postgraduate credentials in aesthetic dentistry from the University of Missouri, Kansas City. A graduate of the, am I saying Coy Center?
Correct?
Yes.
I'm
so sorry, Coy Center and Complex Treatment Planning. Dr. Witten is also a clinical professor at Creighton Dental School. And now it is my pleasure to say, take it away, Dr. Witten.
Thank you, Jessica. Thank you, Eduardo. Well, hello, everyone. I'm so glad that you're here on a Wednesday evening. And for a lot of us, it's pretty chilly out. It's actually, I think, 20 degrees warmer here in Omaha than it was yesterday. So welcome to our webinar calling Enhancing Case Acceptance and Achieving Optimal Results with Clear Aligners. So my hope is that during this whole webinar that we use this as an opportunity to communicate. I would love, as I'm speaking, for questions to be asked. Jessica's going to help facilitate that. But I would really love for any of you, if you're starting out or if you're been doing this for a while, I'd love to have you have this as a participation so that everybody stays awake and hopefully we can enjoy learning from each other. I'm going to be sharing a lot of content. I'm going to be sharing content based on my experiences over 27 years in practicing dentistry, things that I've learned that would help, that we've found that help retain patients, help with case acceptance, help in treatment planning and multiple levels. And again, I would just love for the opportunity for us to interact during this hour. At the end of that, if you still have questions that you'd like to ask anonymously or not, you will be able to ask those questions at the end of our webinar today. Okay. I am not commercially supported by any aligner company. I'm just a National Dentex Labs is just paying me an honorarium for this presentation, but all of my content is my own that I have created, and I have no financial affiliation or corporate organization that's offering financial support for this presentation. Okay, so as we talked about a little bit ago, our webinar is designed to help general dentists harness the power of clear aligners to enhance treatment outcomes, streamline restorative workflows, and deliver superior aesthetic functional results. I have been using clear aligners for over 22 years, and I've used different systems, and I'll touch on that tonight. This course will cover best practices and effective case presentation techniques, and then also retention of those patients after you've completed your orthodontics. At the end of this course, I'm hoping that it'll be you'll have a clear understanding of adding the clear aligner therapy in rehabilitation cases, treatment planning, aesthetic reconstruction, and occlusion corrections. I'd also like for you to be able to effectively communicate the benefits of clear aligners to patients, and then using clear aligner therapy to promote lasting oral health. I think Jessica touched a little bit on my history. Just to give you all of an idea of where I've come from and my practice history. I graduated from dental school in 1997, and then I felt that it was imperative to start my own practice. Was a lot easier back then in 1997 after I graduated dental school. Was easy to open up my doors in a small town, which was a suburb of Omaha. And then after some time, after having a couple kiddos, I decided that I wanted to sell my practice and then take some time to learn from other incredible dentists that taught me a lot about clinical perspective and business aspects of a private practice. And then in 2014, I purchased the practice that I'm at now. And from 2012, I purchased the practice that I'm in now. So I owned it for almost 13 years. And purchasing a practice definitely was probably one of the most challenging things I've done in my career. Learning how to, and really that's how I learned a lot about taking over another practitioner's cases and then trying to facilitate the best outcome for the patients in the middle of somebody else's treatment plan. So I learned a lot about aligners during that whole process. So just like most of you, I'm a part of several different organizations that have helped facilitate education, professional memberships. I am no longer a professor at Creighton, but I was for several years. I was just a clinical part-time faculty there. So why aligner therapy? I did also complete some educational courses and complete some bracket therapy for my patients, and found that through the years, clear aligner therapy has evolved and has done an amazing job for our patients. So how I really started was I can remember I was actually pregnant with my middle son, who's 21 now, and I was going through the Invisalign certification course, just talking about how that evolved. The two students actually created Invisalign. They were the first to commercialize, but it commercialized the system using CAD, CAM, and modeling and 3D printing. And they were the first to actually commercialize it. However, orthodontic appliances had been used previous to that, just not in the same way and not commercialized. So this science has been around for a long time, but we've seen the commercialization with it. The first of those would be with Invisalign. The other companies that I have worked with, and some that I have not, but I'm going to just name a few other clear aligner companies, and I think there's a lot more that are out there and have evolved. ClearCorrect, which I have used. Straumann has now bought them out. Dentsply Sirona. Bite is a direct aligner company to patients. And then Smile Direct Club, which is no longer. They dissolved, I believe, last year for December of 23, I think. And then NDX Aligners. So basically, when we talk about the difference in aligner companies, through the years, they've all evolved to a certain degree. And I personally have used several of them for different purposes as they've evolved and they've gotten better, as the science has gotten better, the CAD/CAM design has gotten better. I have chosen different ones through my practice, depending on what I'm trying to accomplish, to treat my patient, either just for aligner therapy or for maybe a preparation for a rehabilitation case or for implant placement. Also for maybe aesthetic, preparing the patient for veneers. And I'll touch upon some of that later on with some case examples. Okay, so one of the things that I wanted to really talk about is, as I've thought through when I was going to share this webinar, was what are some of the things that I've really that I really see makes a big difference. I've done a lot of different new patient appointments. How and what do we do now that I feel like is really a benefit? And I feel like it takes a lot of stress off our patients and our team that's working with us. We are really big into a full series of photos. So the photography that we use is based on the AACD photography, and then we also have which is the Academy of Cosmetic Dentistry. That's the starting point, and then I've added a few of our own photo series that we do when we are seeing our new patients. So we do a full risk assessment with our patients, looking at occlusion, and just looking at orthodontics and seeing what would benefit the patient. We're looking at if they're having any wear or they're experiencing any wear, chipping, or fracturing. Are they complaining of maybe grinding or clenching their teeth, which is really common right now with our patients? If the patient's complaining of headaches, TMJ, comfort, clicking, discomfort, excuse me, TMJ, discomfort, clicking, or popping. Or if the patients come in and ask about, oh, I'm noticing this crowding or spacing. One of the things I've learned through experience is when a new patient comes into your practice, one of the things you're trying to do is assess who you are as a practitioner, your team, and to really see what you're about and what if you're really willing to listen to them. So one of the things I feel like is really successful and I feel like takes our patients back a step, and they feel like that we're really listening, and we are, to what their concerns are. Some people come in with, I have headaches, or I'm really grinding my teeth. Some people come in and say, I just don't like how my teeth look. I think I want veneers. Or, they don't know what they want, or they're experiencing clicking or popping, or, I've got these two spaces in between my teeth that I don't like. So one of the things that we do is we take time, we interview our patients and just say, what are the things that you're noticing that are, giving you any difficulties in your daily schedule? Are you experiencing any pain anywhere? So we really, and sometimes it takes time to get them to just start talking about what bothers them. And then just seeing what their history is. If they've gone through orthodontics before, clear aligners are not for everybody, but they are for I would say a lot of people, just because the option of using brackets are not appealing to a lot of people, adults and teenagers as well, as long as they can be compliant. So what we do on our first visit, depending on what the patient's coming in for, if I have a patient that's just wanting to come in for an orthodontic evaluation, then we do a full series of x-rays, if you choose to do a pano, but we use a full series of x-rays. As a restorative dentist, that's my preference, so that I can diagnose clearly. Then we will do a full series of photos. At that time, we really make sure those photos are the same and exact on every patient, so that we have an opportunity to communicate with them. Then at that time, the patients will sometimes ask for, what do you think, doc? What should I do? I'll say, I'd really like to spend time reviewing all of your data. We do our a new patient exam, which includes periodontal probing. We do our full case risk assessment. In this case, we're specifically talking about occlusion, or wear and chipping or fracturing, or if they're constricted, their front teeth are constricted. So we're really doing a full assessment. At that point, I just say I'd really like the time to look over all of the data that's in front of me, and then present it at the time of a consultation. And then what I say to them at that point is that this allows me to be very thorough through all of your data. Then also we can look into, if you have insurance coverage, what's your insurance coverage look like? If there's any benefits that are available to you there, and then organize all the financial information. And our patients, I never once have one patient that complains about that. Now, however, if I know the patient is serious about moving forward, meaning they've said, I've already gone to 3 other doctors looking for just your opinion. Then what I'll also do is you can take a scan, and if you have a scanner in your office, which a lot of people do, it's an opportunity to scan and then use that as also a presentation point. So if the patient's like, I am pretty serious about this, just like to see what my options are, then a scan is a great opportunity to also use that in the consultation appointment as well. So when the patient comes back for the consultation appointment, we have everything organized, and we have a TV in our operatory that we screen share, and then we can show them their pictures. And I always say to our patients, no one likes looking at their own pictures, but it's a great way for me and you to really get to see what the issues are, and gives us a mode of communication so that I know what's bothering you and I can tell you what I see. So it gives us a way to communicate, because they can't see in their mouth the way I can. So that's a really big part of just showing them. In fact, a lot of times I just show them and they're like, ooh, I don't like that. Or I don't like how that looks, or what can we do about that? So the scanning can also take another piece of that too, to show them how their teeth come together, how they would really benefit from orthodontic treatment. So typically then the key here that I want to really convey is that you're presenting the problem before you present the solution. Because if you try to tell somebody, oh, you need orthodontics, or you need braces, or you need Invisalign, or you need a clear correct, or whatever system it is that you're using, or you need NDX aligners, a lot of times they get defensive and they shut down before they understand what the issue is. So what's so clear to you as a doctor is not clear to the patient. They just know they have this issue. And then how can this issue solve it? So then before we even present finances, I talk about what it is. We show them what the aligners are, what attachments are, elastics, if we're using that. We spend a lot of time educating them. And then at the end of that, I said, my job is to show you what a solution is to the problem that you and I both agree exists, or sometimes they don't even know exists, but they can see it once they're seeing it on the screen. Then from there, I say, okay, these are the solutions that I have in front of you. And at that point, then I have my financial team, or my manager of my practice, or my treatment coordinator, whichever you have in your practice, to then present the financial piece of that, or the discussion of money. So one of the things that we have felt has been really great for our practice, rather than offering our own in-house financing, which some of you may already do, but we have found third-party financing is a great way to provide a solution for your patients. And there's a lot of different ones out there. I thought about presenting the different options to you, but I felt like that would just maybe go off on a tangent of what we really want to try to avoid right now, focusing on a certain financial institution. But we have used several in my practice. We've tried to find ones that are optimum for patients that have a higher credit score, or ones that don't, so they have options. And one of the things that I have found is successful is when the patient comes to you and you're doing a full mouth orthodontic treatment, you would say, okay, well, this procedure, if you were to pay at this point, let's say just as a round number, $6,000, you can break it into monthly payments for them, rather than just say, okay, if you chose to do this treatment, it's $120 a month or $200 a month. And there's different third-party financial institutions that will actually have a calculator for you to use, so you can present that. So you're not saying, okay, if you chose financing, it's $120 a month for 2 years or a year and a half. And if the patient says, okay, I can do that, or what is it if I just pay up front? So at least it's not overwhelming to them, especially if it's not something they were thinking about, to give them an opportunity to pay for it. So we do not do any in my practice. We do not do any of the financing ourselves. We have that all. We use a third party for any financial financing that we do. for any procedures. So again, this is just a little bit more expansion on what I've just talked about. The patients work with the financial institution to create a payment plan that is tailored to their budget. So we actually, when we do a case presentation, we have the treatment plan printed out, and we put it in a folder with our card, and then we put a couple of different of the ones that we're choosing to use, the financial institutions that we're choosing to use, that we actually will put those in the folder with them so that they can have it. And sometimes they'll just apply for it while they're sitting in their consult, because most of them are pretty quick. And then I think there's banks that actually provide those services as well. If your local banks, potentially dental loans that they can acquire through their bank. There's also basically, a lot of them, Care Credit, that's one of the big ones, but there's a lot of different options out there. And I would encourage that, because it's made a big difference for us. We actually have an app that's associated with some of the facial aesthetics, and our patients will use that. It's very easy that they can actually apply for it on our app through our practice. So those are things you can implement very easily to help your patients pay for things. Okay, so now what I'm going to do is shift into what I've used clear aligner therapy for. Through the years, I have, and again, like I said, when I bought this practice 13 years ago, 2012, I was not forced, but forced when I bought the practice and taking over these treatment plans from another doctor. And so I learned a lot about how to treat more complex cases based on looking at somebody else's treatment plans. It's a great way to learn. So one of the things that I do before we place implants, I don't personally place implants myself, but I will refer the patient to the surgeon, and we'll do a CBCT scan and finalize our treatment plan with the surgeon, and then before I proceed with treatment. And what's beautiful to me about aligner therapy is that you can literally move teeth and create space wherever you need and leave that implant space alone if they're placing a bone graft. So with the surgeons that I work with, I work closely with them so that we can actually utilize the space of the time of healing to complete start, or maybe even be in the middle of orthodontic treatment and implant placement, so that we're utilizing the healing time of the implant placement for the orthodontic treatment. So what I mean is, if I have a patient that we're needing to upright the posterior teeth to allow placement for a premolar implant, I can do all the movement around that, coordinate it with my surgeon so that they're still going through orthodontic treatment at the time of placement. Or we get to a stage where I know I'm not going to be moving teeth anywhere near that implant site, that at the end of that, then they're healing and then finishing the ortho. So then we can place the implant at the end of that. That's worked really well for us, especially when patients come in and they fractured teeth, and their bite is a large part of why those teeth have fractured. So that has become a big part of our treatment planning. And then that, again, requires a good relationship with your surgeon. So orthodontic treatment during full mouth rehab and partial mouth rehab. So one of the things they'll see, and you guys might see this as well, a patient will come into your practice and something motivates them to come in and finally decide to achieve treatment. So, okay, we have a patient that comes in, they have multiple crowns that are failing, they have root decay, they have crowding, they have tooth basically maybe temporaries, and they have teeth that are decaying in different parts of the mouth, and then they have other teeth that are just fine. So it can be overwhelming to look at this. Well, how do I don't want to really build these crowns based to the occlusion that it's at. So what we'll do is I will then sit down and present to the patients. What I want to do is remove the decay, put you in temporaries so that we're getting everything healed up. We're doing any perio treatment that we need to do. We're removing any carious lesions and then placing those patients in a really good temporary that I make myself, and I make them per tooth so that I can actually then put the patient in orthodontic care. And that's what I love about a clear aligner therapy, is that I can actually treat each tooth as I need, and then the patient can clean around it. And then I've had patients that have even been in aligner therapy for 2 years, so we can get their occlusion right where I want it. And at that point, once I have that occlusion established, then we start finalizing the restorations after they've completed the orthodontics. A question that's been asked to me previously is that, so, okay, now they're in temporaries, doesn't that cause decay? No, as long as you have good temporaries and their patients are keeping it clean, they're coming in for their cleanings, they're seeing you regularly for your orthodontic treatment. No, I mean, as long as the patient is committed to keeping things clean and changing that. Again, looking at what's causing the decay, what's causing the risk, and trying to mitigate that risk by treating it. And I've seen great success with this, so that I'm then establishing a great occlusion and then taking care of the disease and the decay or perio, whatever is the issue that the patient comes to your office with. Okay, so another thing that I have discovered is in the cosmetic treatment that I've done on patients that I've completed. Okay, they go through ortho and then orthodontic treatment. They've done clear aligner therapy with you. Then you have now restored 4 through 13 with veneers. And I'm adamant about getting my patients scanned. We print our models and then we make retainers for our patients within a few days, so that they, even during the time of temporaries, so that we don't have tooth movement. Well, we still know that that can happen, right? We know that teeth can shift. We know that maybe they're not compliant. We know that sometimes those ligaments are really bent on going back to where they were. So I've actually seated final veneer cases, and then we've seen some shifting. So the patient's like, comes in, oh no, I swear I've been wearing my retainers, those teeth have shifted. So what I love about clear aligner therapy, especially now we've got so many great options, that you can go to a clear aligner therapy and say, I need 5 trays, that I just need to do some shifting back into place. And that's beautiful, because then you include that into your veneer case, just as part of what you're going to do to make things right, even though maybe the patient really wasn't wearing their retainers. But it really is a motivating factor. They can see, it really does motivate them. They can see how their teeth can shift, and how important it is they wear their retainers. So I have used this technique for crowns and veneers, also posterior crowns. Some of you, I'm sure, have experienced where you've seated crowns, or 2 or 3 crowns maybe, and then you have some posterior shifting. Maybe they're clenching, or really they really need to go into orthodontics and they're not. And then I'll say, okay, well, we can at least close that space back up with adding a few aligners, never a couple, but a few aligners, and basically close those spaces. And that's the beauty of what we have in front of us with aligner therapy, that can help us finish things where, rather than redoing a crown, which really has nothing to do with the crown itself, just maybe the contacts have shifted a little bit based on their occlusion changing, or not wearing retainers or occlusal guards. Okay, so one of the things I wanted to mention is that patients that we'll see now, we'll see a lot of erosion related to maybe acid reflux, related to maybe use of acidic drinks. Energy drinks is a big one. So we'll see a loss of vertical dimension. Or just how their body developed. And then maybe you're starting to see a patient clench or grind. I use this a lot. In fact, on almost every case that I'm doing a full aligner case on, I will look at where their vertical dimension is, if they're lingually inclined, or if they're constricted in the anterior. And I do a lot of expansion and what I would call expansion or uprighting of those posterior teeth to allow for increased vertical, so that the patient is not articulating on their buccal cusps and their lingual cusps of the buccal cusps of the maxillary arch and the buccal cusp of the mandibular arch. So then what that does is it literally puts extra pressure on the buccal bone, buccal tissue, and you can see tissue loss, can see abfractions. So if I'm seeing a patient that I'm actually trying to treatment plan for fixing or correcting an occlusion, that's one of the things I'm always looking at. And clear aligner therapy is one of the main things I use because it's the least invasive. And then a lot of times the patients find that they're more comfortable. It's more supportive of their joint, their discs in their TMJ. So that's something that I'm always looking at when I'm either treating a patient just for their occlusion, but also as a technique for creating space for final restorations, whether it's veneers or crowns, to make sure that I'm setting up the correct posterior occlusion for the patient. Which also I want to mention does include decreasing the curve of SPE. That all plays into that as I'm treatment planning. So here's some of my case examples that I'm going to share with you. This was actually for one of my AACD accreditation cases that I worked on several years ago. It was a composite veneer case, and this is the patient prior to prior to orthodontics and composite veneers. He was fairly constricted in the anterior. We did try some other aligner therapy, not clear aligner therapy, but more of a wire aligner therapy that didn't work very well, and it wasn't predictable. So with this case, I specifically used Invisalign. And you can see the expansion and upright of his maxillary arch really is what we were trying to do to create less constriction of those anteriors there. And so this was prior to orthodontics, Invisalign, and then this is after I placed composite veneers. And I ended up actually, and I don't have post pictures on this, but I ended up doing porcelain veneers at the end rather than composite veneers because I could get more of a dynamic response for the patient. So again, you can see really just uprighting the bite, uprighting the smile, and then changing that with adding the two-side discrepancy here you can see, and then we just added some composite veneers to change that. That's just another side view, seeing the benefits of just, again, it wasn't a huge investment. It was more of a limited occlusion that we were trying to achieve. So it was a limited orthodontic case. And so we did some, I think we were in aligners for 6 months, and then we went into just getting the composite veneers finished. And then I went on to the porcelain veneers later. So this patient came to me. I had completed his wife's veneers, and he said, I really think I want veneers now. And he came to me with this occlusion here. And I think the Invisalign ClinCheck shows this really well, where he is occluding on really his maxillary anteriors, right lingual there, and how tight his bite is. But he really didn't know really what he wanted. He thought he wanted veneers, but once we did the orthodontic work, once we did Invisalign, he was really happy with the outcome. And so was I. So this is exactly how he ended up with the ClinCheck here, showing the benefits of just really, and I told him, I said, you may not feel like you want veneers after this. We'll just do that assessment later. So we didn't even treatment plan veneers. We just started with the orthodontics and said, okay, we're going to start here and just see where we end up if that's what you're looking for. That's what I talk about a lot, is if this is what you're looking for. If not, then we can go down in that road of treatment planning, any more cosmetics. But he's still, at this day, he's just done some whitening and thrilled with his orthodontic treatment. And then two, I wanted to note, as we're looking at this slide, this is really what I'm talking about. Do you see how the mandibular molars are lingually inclined, and then the maxillary molars and premolars are buccally inclined? So really what I do when I treatment plan these cases, you can see this is exactly how he ended up. We really upright everything is how I describe it, so that we're creating more of an occlusion that is straight up and down and is supportive of those tissues. And two, when you look at the pre-op picture, this is something I wanted to point out. Do you see how the teeth have really, to accommodate the bite, our bodies adapt. And so those mandibular posterior teeth are really lingually inclined to accommodate the deep curve of SPE and to accommodate the occlusion and the pressure that those maxillary teeth are trying to provide for that whole occlusion. And then you can see down here the appreciation that we have for the uprighting of those, basically most of those teeth, in the posterior and anterior. Okay, this is orthodontic correction for a TMD treatment. The patient come to me with clenching and grinding. We started out doing neuromodulators, so injecting into his masseters and his we started with just masseters, and then he felt like things were not progressing, so then I added the temporalis. And then we started talking about, where his occlusion was, because he had been through orthodontics prior to, but he didn't wear his retainers. And how often do we hear that? And I took this picture with the occlusal papers, and you can see how he's constricted here in the anterior. And then how he's actually occluding on the lingual, which isn't bad. So his teeth haven't shifted all that much, but he's really putting a lot more pressure in the anterior here. And we really need to establish more of a home in the posterior teeth. So that's his pre-op. And then this case is actually through NDX aligners. I've been able to speak to the orthodontist in development with them and really appreciate what I'm seeing. This actually is pre-op. And then the whole goal, like we were talking about, is to, and you can see how different this is, upright the mandibular posterior teeth and the maxillary posterior teeth to create more of a stable occlusion in the posterior. And you can see a huge difference between here and here. And so this is actually, this patient's currently in treatment, and he's feeling so much relief that we're no longer having to complete any neuromodulator injections. So not to say that we may not have to do that in the end, but right now he's feeling so secure in his occlusion in the posterior that that's taking a lot of pressure off his joint and then his need to clench or grind. So this is similar picture, but then I wanted to show that NDX's version of a a ClinCheck, and he's in elastics to help support the class 1 correction. And we're doing a little, you can see the attachments here. We're doing a little IPR. Okay, so one of the things I wanted to share with you about aligner therapy that we have found has been very beneficial to our patients, that we no longer give our patients or place attachments or elastics on the first visit. We give the patients one aligner to wear so they get used to it, and it can be 1 to 2 weeks. NDX, their recommendation always divert to the doctor and what they seek, but is 1 week per aligner. So I always say 1 to 2 weeks just to give the patient time to get used to it. I have found that patients get really frustrated if you're placing them in aligners with a lot of attachments. It's hard to get them off. So once they get used to that, the second appointment, we place attachments and deliver elastics. We've had a lot more compliance with this and a lot happier patients. The other things that we've used, I know there's a lot of things out there now on the market to take aligners out. NDX does provide a liner removal, and then chewies, which we prescribe or give our patients bite sticks or tongue depressors. A lot of the aligner companies have what's called chewies now that the patients can use to make sure they're seating those aligners. That's really important over those attachments, because as the teeth shift, the attachments need to make sure those are fully engaged. So those are some of the things that we've added in. One of the things I wanted to mention that we have found can be very frustrating for attachment placement. We have cut depending on how many templates or how many attachments the patient has, we cut the templates in quadrants. So it just makes it really easy to keep things dry. So I use an Optrogate, we use dry angles, and then I don't care where you're working, you're wanting Optrogate, dry angles, cotton rolls, and having your assistant suction, making sure things dry, because really that is one of the things that causes the most failure. Making sure the tooth surface is clean. You can use pumice, you can use Conceptus, whatever it is your technique is, just making sure that surface is clean. If you've had an attachment come off, you want to clean that off with your handpiece, removing any excess so that you've got a clean surface to bond to. And whatever bonding agent that you use, follow those rules, and then put the attachment templates on, and then only cure each attachment for 10 seconds. Otherwise, you'll melt the plastic. That might be different depending on your light. So pay attention to that. If you've got a high powered light, maybe longer if your light isn't as powered. So that's something that's a big deal. Once you've cured each of those, we pop the attachment templates off, and then we continue curing those for 20 seconds, again, depending on your light. Okay. So let me go back here. We've got about 12 minutes, and I didn't see any questions prior to my word vomit, I guess, for almost an hour. So I'd love to hear questions or interactions or anything that anybody wants to share or their experiences.
Right now, there isn't any questions, but save this slide up because I'm going to go ahead and steal the screen for
Okay.
a couple minutes. So while the audience is thinking about what they would like to ask, I'm going to go ahead and, oops, my presenter mode covered up my share button here. Here we go. So I'm going to announce we've got some more courses coming up. As you can see, we have Dr. Carrie Winton. This program is going to be put in our platform that she presented this evening. So if you have any colleagues or friends that you would like to recommend, hi, Dr. Peter. He's a regular, Dr. Witten, so I always make sure to call out, and he always pops in the chat box to say hello. Audience, we welcome that all the time because we do want to know your names and get to know you virtually as well as remotely. Anyway, so Dr. Witten's presentation will be curated in our on-demand platform. So that way, if you want to share this with inside your staff or with any colleagues or friends, give us about 30 days to have it fully loaded and we'll have it ready for you. And then we also have creating an enhanced patient experience coming up. And that is with Dr. Brian Laskin. We are having him back. That's Tuesday, January 28th at 7 p.m. Eastern. He is coming to speak with us on kind of like a mini 3-part series. And Dr. Witten has a 2-part series. So you'll get to see her again in April. So I am going to stop sharing my screen. Ooh, did it even share, Eduardo? Or are you still seeing questions in group interactions?
No, it did. Yes.
Oh,
Your slide was up.
okay, great. And now we're back to questions in group interaction. Wonderful. Sorry, that's the perils and blessings of working with 3 monitors. It looks like we do have some comments in the chat box there. Thank you very much, Dr. Witten. Very informative. Dr. Peter saying hello and wishing everybody a lovely night. So it doesn't appear there are any questions, audience. Both Dr. Witten and Eduardo are here to serve. So if you have anything that pops into your head later this evening, tomorrow, down the road, as you talk with your practice and staff, they're here to help you along your educational journey. So please don't hesitate to reach out. And with that, Dr. Witten, do you have any closing remarks?
Yeah, so if you have any questions, also Eduardo and Jessica, if you have anybody that would like to get a hold of me via phone, if you want to talk, I love to answer any questions at all specific or send me any cases to review. I'm happy to do that. We just feel like in this day and age, the instant messenger via Instagram is a great way to communicate. If that's not for you and you just want to call the office and just talk to me, I'm happy to do that. Or set up a time like with Jessica or Eduardo to get a hold of me would be fine too. So